What is the main histological characteristic feature of cirrhosis? Cirrhosis is characterized by the presence of multiple fibrous septae throughout the liver. These septa divide the parenchyma into hepatocellular nodules. In this slide of cirrhotic liver, we can see multiple fibrous septae all over slide, with residual liver parenchyma divided into nodules. What is the cause of cirrhosis? Cirrhosis is the consequence of chronic liver injury with wound healing, so we have injury and healing going side by side. What is most common symptom of cirrhosis? Most patients, 40%, with cirrhosis are asymptomatic, means these patients progress to cirrhotic phase without any specific symptoms. What is main cause of death in end-stage liver disease? 70% of deaths in end-stage liver disease is due to liver failure. What is morphologic classification of cirrhosis? Morphologically, cirrhosis can be described as micronodular, macronodular, or mixed. Micronodular means liver is filled with multiple small nodules, while macronodular has larger sized nodules. Mixed have varying size of nodules. What is importance of this morphologic classification? Earlier nodule size was correlated with causation, but later multiple studies show that this morphologic classification correlates poorly with causative factor, and the same pattern can result from a variety of disease. What are the main features of cirrhosis? The cirrhotic liver frequently demonstrates right hepatic lobe atrophy, caudate lobe and left lateral segment hypertrophy, recanalization of the umbilical vein, a nodular surface contour of liver, dilatation of the portal vein, gastroesophageal varices, and splenomegaly on radiographic evaluation. What are the causes of cirrhosis? Non-alcoholic fatty liver disease, chronic hepatitis C, chronic hepatitis B, alcohol, autoimmune, hereditary, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency. What is the most common cause of chronic liver disease worldwide? Non-alcoholic fatty liver disease is the most common chronic liver disease worldwide. What is NASH? NASH is non-alcoholic steatohepatitis. It is a progressive form of non-alcoholic fatty liver disease. Steatohepatitis means inflammation of liver, in presence of fat deposition. It is a consequence of fatty liver. What are the requirements for making diagnosis of NASH? The diagnosis of NASH requires the demonstration of steatohepatitis on biopsy, the lack of a history of significant alcohol consumption, and exclusion of other causes of fatty liver. What is cryptogenic cirrhosis? Cryptogenic cirrhosis means cirrhosis due to hidden causes, once a common designation. When no apparent cause of cirrhosis could be found, proportion of cryptogenic cirrhosis has declined over time, because many of such patients may actually have unrecognized NASH. What are the symptoms of cirrhosis? Fatigue, anorexia, weight loss, jaundice, abdominal pain, peripheral edema, abdominal distension due to ascites, lower GI and upper GI bleeding, and altered sensorium due to hepatic encephalopathy, muscle cramps. What are the findings on examination? Spider angiometer, palmar erythema, finger clubbing, white nail beds, Dupuytren's contractures, splenomegaly, ascites, pleural effusion, caput medusae, Creuvel-Baumgarten murmur, jaundice, asterixis, fata hepaticus, temporal muscle wasting. Males may develop features of feminization such as gynecomastia, loss of chest and axillary hair, and testicular atrophy. What is the cause of spider angiometer and palmar erythema? spider angiometer and palmar erythema are believed to be caused by alterations in sex hormone metabolism. Why is there finger clubbing? Finger clubbing may be a consequence of hypoalbuminemia. Is cirrhotic liver palpable? The cirrhotic liver itself may be enlarged, palpable or non-palpable when normal-sized, or small. What is Creutzfeldt-Baumgarten murmur? Creutzfeldt-Baumgarten murmur is a venous hum, auscultated in the epigastrium resulting from collaterals between the portal system and the remnant of the umbilical vein. How do you screen cirrhotic patients for hepatocellular carcinoma? Every cirrhotic patient should undergo screening for the development of hepatocellular carcinoma every 6 months via imaging and measurement of a serum alpha-fetoprotein level. What is effect of cirrhosis on cardiovascular system? Cirrhosis is associated with increased cardiac output and heart rate, as well as decreased systemic vascular resistance and blood pressure. What are the findings on blood investigations in cirrhosis? The cirrhotic patient usually has a mild normocytic normochromic anemia. The white blood cell and platelet counts are reduced, and the bone marrow is macronormoblastic. The prothrombin time is prolonged and does not respond to vitamin K therapy, and the serum albumin level is low. The serum levels of bilirubin, transaminases, and alkaline phosphatase may be elevated. Can cirrhotic patients have normal liver function test? Yes. Normal liver function test results do not eliminate the possibility of cirrhosis. Is liver biopsy necessary for diagnosis of cirrhosis? No. The diagnosis of cirrhosis can be made in many cases by clinical features, blood investigations, and radiology findings. Histopathologic examination of liver tissue is occasionally needed to confirm the diagnosis. What is elastography? Ultrasound elastography, which measures the stiffness of the liver by inducing an elastic shear wave that propagates through the tissue, shows promise as a non-invasive test in identifying patients with advanced fibrosis. How is hepatic reserve assessed? Tests of indocyanine green, sorbitol, and galactose elimination capacity, as well as the carbon-13 galactose breath test and carbon-13 aminopyrine breath test, the monoethylglycine xylidide, MEGX, test, which measures MEGX formation after the administration of lidocaine. MEGX is a metabolite of lidocaine and is formed in liver. What is Child-Turcotte-Pugh score? Child-Turcotte-Pugh score was originally developed to evaluate the risk of portocaval shunt procedures performed for portal hypertension. It predicts overall surgical mortality rates in cirrhosis. There is mortality rate of 10% for patients with Class A cirrhosis, 30% for those with Class B cirrhosis, and 75% to 80% for those with Class C cirrhosis. There are 5 parameters: ascites, encephalopathy, bilirubin, albumin and prothrombin time or INR. Each is given 1, 2 or 3 scores based on levels, and final score is generated by adding all of them. What is lowest score and highest score in Child-Pugh score? Lowest possible score is 5 and highest possible score is 15. What is MELD? The model for end-stage liver disease, MELD, is based on 3 laboratories values: INR, bilirubin level, and creatinine level. It was originally developed as a tool to predict mortality after transjugular intrahepatic portosystemic shunt, TIPS, but now used as a method of liver transplant allocation. What is formula of MELD? The MELD formula includes natural logarithm of creatinine, bilirubin and INR, multiplied with constants. What is importance of MELD? MELD score was the significant predictor of 30-day mortality. Patients with MELD scores in excess of 15 should not be subjected to elective surgical procedures. What is normal portal venous pressure? The normal portal venous pressure is 5 to 10 mmHg. What happens in portal hypertension? As portal venous pressure increases, however, the collateral communications with the systemic circulation dilate, and a large amount of blood may be shunted around the liver and into the systemic circulation. What is finding on ultrasound in case of portal hypertension? A large portal vein on ultrasound suggests portal hypertension. Which other investigation is capable of evaluating portal vein? Doppler ultrasound, CT, magnetic resonance angiography, visceral angiography and portal venography. Which investigation can identify the direction of portal venous blood flow? Doppler ultrasound. What are the other uses of Doppler ultrasound in portal hypertension? Doppler ultrasound also is useful in evaluating blood flow through surgical shunts and tips. What is the most accurate method of determining portal hypertension? Hepatic venography. How is hepatic venography done? A balloon catheter is placed directly into the hepatic vein and measuring the free hepatic venous pressure with the balloon deflated and the wedged hepatic venous pressure with the balloon inflated to occlude the hepatic vein. The hepatic venous pressure gradient is then calculated by subtracting the free from the wedged venous pressure. The hepatic venous pressure gradient represents the pressure in the hepatic sinusoids and portal vein and is a measure of portal venous pressure. What is the normal value of hepatic venous pressure gradient? Portal pressure gradient greater than 5 mm Hg is called portal hypertension. Clinically significant portal hypertension is evident when hepatic venous pressure gradient exceeds 10 mmHg. What is the most common cause of portal hypertension? The most common cause of portal hypertension is usually an intrahepatic cause, mainly cirrhosis. What is the most common cause of prehepatic portal hypertension? The most common cause of prehepatic portal hypertension is portal vein thrombosis. What is most common cause of portal hypertension in children? Portal vein thrombosis accounts for approximately 50% of cases of portal hypertension in children. What is left-sided portal hypertension? It is isolated splenic vein thrombosis, usually secondary to pancreatic inflammation or neoplasm. What are post-hepatic or post-sinusoidal causes of portal hypertension? Budd-Chiari syndrome, constrictive pericarditis, and heart failure. Can massive splenomegaly cause portal hypertension? Yes, massive splenomegaly can cause portal hypertension due to increased portal venous flow. What is the most important clinical finding of portal hypertension? The most significant clinical finding associated with portal hypertension is the development of gastroesophageal varices. These varices are basically small vessels connecting portal and systemic circulation. Increased blood flow through them causes them to dilate, but in course of dilatation their wall becomes very thinned out, hence they are prone to rupture. What is the main supply of these varices? Main supply of gastroesophageal varices are anterior branch of the left gastric vein, which is also known as coronary vein. Why is there pancytopenia in portal hypertension? Splenomegaly is frequently associated with functional hypersplenism, leading to increased destruction of blood cells causing leukopenia, thrombocytopenia, and anemia. Why are there visible collaterals on abdominal wall? The umbilical vein may recannulate and dilate, leading to visible collaterals on the abdominal wall. This umbilical vein is connected to left portal vein in foetus and obliterates after birth. In case of increased portal pressure it pops open leading to blood flow up to umbilicus causing caput medusa. What is the cause of fresh blood per rectum in portal hypertension? Anorectal varices are present in approximately half of cirrhotic patients and these are different from hemorrhoids, which do not communicate with the portal system. Is there increased incidence of hemorrhoids in cirrhosis? Piles are not present at increased incidence in patients with portal hypertension. What is the leading cause of mortality in portal hypertension? The leading cause of morbidity and mortality in portal hypertension is variceal bleeding. Varices are present in how many cases of portal hypertension? Approximately 30% of patients with compensated cirrhosis and 60% of patients with decompensated cirrhosis have esophageal varices. How is variceal bleed prevented? Administration of non-selective beta blockers and prophylactic endoscopic surveillance with variceal band ligation. How many patients do not respond to beta blockers? However, approximately 20% of patients do not respond to beta blockade. How is acute variceal hemorrhage managed? Blood resuscitation should be performed to reach a hemoglobin level of approximate. Administration of fresh frozen plasma and platelets can be considered in patients with severe coagulopathy. Use of recombinant factor VII is not recommended at this time. Prophylactic antibiotics must be given. Vasopressin or terlipressin decreases blood flow to the gastroesophageal varices and can be initiated as soon as the diagnosis of variceal bleeding is made. Octreotide is currently the preferred pharmacologic agent for initial management of acute variceal bleeding. Endoscopy with variceal band ligation should be carried out as soon as possible. What can be done when medical and endoscopic measures fail to control variceal hemorrhage? When medical and endoscopic measures fail to control variceal hemorrhage, balloon tamponade using a Sengstaken Blakemore tube will control refractory bleeding in up to 90% of patients. What is the maximum duration for which you can keep Sengstaken Blakemore tube inflated? The use of a Sengstaken Blakemore tube should not exceed 36 hours to avoid tissue necrosis, and this treatment modality should only be considered a temporary bridge to more definitive measures of variceal hemorrhage control. What is TIPS? The TIPS procedure involves implantation of a metallic stent between an intrahepatic branch of the portal vein and a hepatic vein radical. TIPS can be performed by an experienced interventional radiologist. Controls variceal bleeding in 90% of cases refractory to medical treatment. If patient is waiting for liver transplant, should TIPS be done? TIPS does not affect subsequent hepatic transplantation, as stent is intrahepatic and will be removed with old liver. What are complications of TIPS? Bleeding either intra-abdominally or via the biliary tree, infections, renal failure, decreased hepatic function, hepatic encephalopathy in 25–30%. Post-typos as impure blood enters systemic circulation through stent thrombosis due to narrow diameter. What is BRTO? The balloon-occluded retrograde transvenous obliteration (BRTO) procedure is used for the specific management of bleeding gastric varices in patients with spontaneous gastrorenal or splenorenal shunt shown on contrast-enhanced cross-sectional imaging. Using a transjugular or transfemoral approach, a balloon occlusion catheter is directed through the left renal vein into the spontaneous shunt, which is then obliterated with the use of a sclerosing agent. What is advantage of BRTO over TIPS? BRTO preserves portal flow to the liver, thereby reducing the risk of hepatic encephalopathy relative to TIPS. What is the risk of BRTO? The occlusion of spontaneous shunts can exacerbate portal hypertension. What is the aim of shunt surgeries? The aim of the surgical shunt is to reduce portal venous pressure, maintain total hepatic and portal blood flow, and avoid the high incidence of complicating hepatic encephalopathy. What is Eck fistula? The portacaval shunt or Eck fistula, as first described by Eck in 1877, either joins the portal vein to the IVC in an end-to-side fashion and completely disrupts portal vein flow to the liver, or joins it in a side-to-side fashion and thereby maintains partial portal venous flow to the liver. What is disadvantage of Eck fistula? High incidence of hepatic encephalopathy and decreased liver function resulting from the reduction of portal perfusion. The Eck fistula also makes subsequent hepatic transplantation much more technically difficult. What is mesocaval shunt? The mesocaval shunt uses an 8 or 10 mm polytetrafluoroethylene graft to connect the superior mesenteric vein to the IVC. What are the advantages of the mesocaval shunt? Mesocaval shunt is technically easier to perform and can be easily ligated during subsequent hepatic transplantation. The smaller caliber of the shunt avoids the deleterious effects of portal blood flow deprivation on hepatic function. Small diameter portosystemic shunts have been reported to reduce the incidence of encephalopathy. Which is the most commonly used shunt in portal hypertension? The surgical shunt currently used most often is the distal splenorenal or Warren shunt. This shunt is technically the most difficult to perform. It allows splenic vein to drain directly into the left renal vein via an end-to-side splenic to left renal vein anastomosis. What are the advantages of Warren shunt? This shunt has the advantages of being associated with a lower rate of hepatic encephalopathy and decompensation and not interfering with subsequent liver transplantation. Which shunts are the most effective shunt procedures for relieving ascites? Because the liver and intestines are both important contributors to ascites formation, side-to-side portosystemic shunts are the most effective shunt procedures for relieving ascites and preventing recurrent variceal bleeding. Which shunt must be avoided in intractable ascites? Because sinusoidal and mesenteric hypertension is maintained and important lymphatic pathways are transected during dissection of the left renal vein, the distal splenorenal shunt tends to aggravate rather than to relieve ascites. Thus, patients with medically intractable ascites should not undergo this procedure. What are other contraindications of distal splenorenal shunt? Apart from intractable ascites, prior splenectomy, splenic vein diameter less than 7 mm are contraindications for doing Warren shunt. Which part of splenic vein is best suited for splenorenal shunt? Distal part of vein, as it is wider than proximal vein, hence less chances of thrombosis. What is Inokachi shunt? Left gastric vena cava shunt, which consists of interposition of a vein graft between the left gastric vein and IVC. Therefore, it directly and selectively decompresses esophagogastric varices. What is partial shunt? Partial shunt preserves hepatoportal flow while decompressing portal venous system. Example is portal cavole anastomosis with PTFE graft diameter less than 10 mm. What is the non-shunt surgery for controlling excessive variceal bleeding? Suguro procedure. What is Suguro procedure? The Suguro procedure consists of extensive devascularization of the stomach and distal esophagus along with transection of the esophagus, splenectomy, truncal vagotomy, and pyloroplasty. Which procedure in portal hypertension must be avoided? If liver transplant is planned, previous creation of an X fistula makes hepatic transplantation much more technically difficult, and therefore this procedure should be avoided in the transplant candidate. However, endoscopic variceal band ligation, TIPS, or splenorenal or mesocavole shunts can be done.
Join our YouTube channel to learn surgery in a simple way.